So let's start with how to approach a case of spine infection. Now I'm going to kind of be talking, I'm going to be giving cases, and I'm going to be stopping, and Dr. Rasouli is going to talk about all of the clinical aspects. I'm going to do the imaging aspects. And we'll take a little break maybe halfway through to answer questions. And then at the end, we'll answer questions. We'll have a little break between the infection talk and the tumor talk. And then as Ryan said, you'll get to do more working through these cases yourselves with our great faculty at the end after us. So you'll have your 3 groups and go through each trauma, infection, and tumor sessions again. So with that, how to approach a spine infection. And you'll have to let me know if you can see my arrow. Can you see my arrow, Dr. Rasouli?
I can, yep.
Yes, good, okay. So this is gonna be case-based. So I'm gonna start with this case. This was a 56-year-old woman who had neck pain, who went to an urgent care clinic, and she lived in an underserved area where she didn't really have good medical care. So the doctor at that urgent care ordered an X-ray, and this is what the X-ray looked like. And if you were present at our first session a month ago, Dr. Rasouli talked about the anatomy of the cervical spine a little bit. So you will remember, or if those of you are new, we'll explain it again, that this is not a normal looking X-ray. So this is a lateral view of the cervical spine. And when we look at these, we look at the spinal alignment, which is everything's lined up, normal alignment. We look at the height of the vertebral bodies. We look at the disc space height. All those things are normal in this case. But one thing that's abnormal in this case is the soft tissues in front of the cervical spine. You should not really be able to notice those very much. They should be pretty close to the cervical spine. So something is wrong here. Now, I'm not sure when this got read, and I don't know if the results got conveyed to the patient because she didn't get any further care until she came into our ER. This was at my prior institution, 3 weeks later with this appearance on a CAT scan. So no, the first picture is an X-ray. That's why I just showed you. I flipped it around. So it's the same as this CAT scan. And I'm assuming nowadays, as medical students, you all know what a CAT scan looks like, what an X-ray looks like, and even an MRI basically. So I don't want to go into too much detail. But you can see on this lateral view, the sagittal view, as we call it for CT and MR, of the cervical spine, that there have been some changes since that X-ray. Here at the C3, C4 level, now these vertebral bodies do not have normal vertebral body height anymore. This disc is gone. There's no longer normal disc space height. It's not aligned anymore. It's not a straight line like it used to be. So now there is destruction, and there's what we call subluxation of this C3 vertebral body into the spinal canal. And we still see these very prominent prevertebral soft tissues, which is very abnormal. Now this person got another CAT scan with contrast, and that's not the normal way things go, but in some county hospitals where this was taken, MRI was not immediately available. So this is what the surgeons did for surgical planning until they could get the MRI, because this was kind of a case they wanted to treat emergently. You can see again, there is subluxation. We've lost our normal alignment of the cervical spine. Here, there's a little bit of enhancement. This is a post-contrast CAT scan. A little bit of enhancement in front of the spine and behind the spine. This is the epidural space, and this is the prevertebral space, and there should be no soft tissue and no enhancement there. Now, this is an axial view, cut straight through like this, if you can see me at the top. And you can see there, this is the vertebral body. These are the posterior elements. This is the spinal canal. And there's abnormal enhancement in the front of the spinal canal, which is epidural. It's phlegmon, which is inflammatory tissue on its way to becoming an abscess, and prevertebral phlegmon or abscess. So this is a surgical emergency, or is it? Actually, let me stop there. So this case came into the ER. So the ER doc evaluated it first. First thing he did, order imaging. I read these images. Now, who's consulted? Dr. Rasouli. Who comes in first? Is it you? Do you send your medical student?
it would be a resident. Let's just say theoretically, if this was at an academic center, so the resident would come and evaluate this patient, or a medical student, who would then ultimately sign this out to a resident, who would then ultimately make its way over to me. So the short of your question is yes. Ultimately, this is a patient who definitely needs neurosurgical care. So let's look at it. You literally hit all the points, nails on the head in terms of all the kind of the detailed aspects of this patient's imaging. Let me talk a little bit about more how I look at this in terms of surgical planning and some of the clinical characteristics. So as you mentioned before, you can see this patient has very significant prevertebral soft tissue swelling, okay? Now, very rarely can this compromise the patient's airway, all right? So the first thing I look at is look at the trachea in front of the soft tissues. You know what, you can't see my pointer, but you can see that it's totally patent, right? So this patient's not having any breathing difficulty. So that's good, all right? So the patient's airway is secure. Now, the next thing is looking at the patient's alignment. So look at the CAT scans compared to the patient's X-ray. So although the X-ray was a little bit abnormal, look at the alignment, right? Remember in the last week's sessions, I don't know if you guys were here, but I talked about contour lines, right? There were 4 of them: anterior, posterior, spinal laminar, and the spinous process contour lines, right? So if you just draw kind of straight lines down the fronts and backs of the vertebral bodies, behind the lamina and the spinous processes, you just kind of want to see a smooth, gradual transition between each one of those things, right? On the X-ray, it looks pretty good, honestly. But if you look, I mean, you don't need to have a spinal surgery background or a neuroradiology background to know something looks very abnormal there, all right? So what you see here is basically, this is pretty characteristic of osteomyelitis, discitis, and an epidural abscess around C3 and C4 vertebral bodies. You can see there's destruction of C3, there's collapse of the vertebral bodies, and there's basically kyphosis that's developing above, okay? So a general rule of thumb is the disc spaces, for the most part, should be parallel with the floor, okay? Look at the C2-3 disc space, right? It's essentially at a 45-degree angle from the floor, right? All right, well, that's not normal, okay? And something needs to be done about it. Now, the question is, what would have been nice here, but not necessary, this patient needs surgery. There's essentially no question about that, right? Sometimes what I like to get in these cases, assuming that the kyphosis wasn't that bad, is a APN lateral X-ray, and usually these patients are wearing collars with a collar on. And I can tell you a lot about what this patient's alignment would look like in a collar. If there was even a question that conservative management could be the option for this patient, which is not, I want to preface that, but if you were thinking about conservative management, you could get an APN lateral X-ray with the patient in a collar to see what their alignment was. And you cannot, I want to kind of stress this, you cannot judge a patient's alignment based on a CT or MRI. It does not give, remember, these patients are laying supine and they're not bearing any weight when they get these images done. However, with X-rays, they are the most physiologic imaging modality that you will be able to have. So although it's become a little bit passé, it's falling back into favor now to get X-rays on a lot of our patients because it's just amazing the amount of information you get from them. Anyway, I don't want to get too much into that. So anyway, so this patient clearly has destruction of C3 and C4, subluxation of these vertebral bodies, spinal cord compression. I don't know what the patient's neurologic exam is, but it would be important to know. And the timing of the surgery, although this is an emergency, right? There's certain things that I think about as a surgeon that are important, okay? So I hate to say this, but the time of the day that this patient arrives and the time of the day that you're planning on taking this patient to surgery is very, very key, because it's very different taking a patient to the OR at 2 o'clock in the morning as compared to 7 o'clock in the morning, all right? Again, I hate to say that, but it's just the fact of life. So if this patient is neurologically intact, which often they are, okay, and they had this scan, and let's say this patient came in at midnight, I'm okay waiting until 7 o'clock in the morning to take this patient to the OR, okay? Or maybe I could even take it the next day or during the week, assuming they came in over the weekend, all right? The neurologic exam trumps anything else you see on imaging, all right? The next thing is, if this patient was actually neurologically compromised, if they had some sort of findings, then that becomes a moot point. You have to take this patient to the OR ASAP, all right? So,
is pain a neurologic finding? She had severe pain. Okay, no doubt it's just pain.
Pain can be managed. So now the thing, and usually the pain is due to instability and just kind of inflammatory pain from the infection itself. And those things can be managed with medications and a collar and things like that. Because again, when you take a patient to the OR if you make the decision to take the patient to the OR at like 2 o'clock in the morning, the team, the staff that you're dealing with is very, very different. And in particular, a weekend team is very, very different than the staff that you're going to be dealing with, let's say Monday morning at 7 o'clock. And it adds more layers of challenge to you as a surgeon in terms of getting this procedure done safely for the patient. And I hate to say it, but it is a big factor. It is a big factor. Now, that's no longer a factor if the patient is emergent, and then you just have to kind of deal with those things. Okay. Now, I guess the next question I could talk about is which approach is this the same? This is not the same patient, right?
No, let's wait on your approach. Or
Okay,
you can say which approach to surgery.
We'll circle.
Because I have an MRI for this one if you want to see it.
Sure.
I don't know if you want to see it. You're going to decide without it. You're going to decide on your surgery with these two.
Here's the thing. Yeah, the patient needs surgery regardless of whether the MRI shows. So the MRI, while it's nice, it would, to me, I would take the patient based on the CAT scan, unless I was really concerned that there was something else going on, like there was some big abscess there. It would guide my levels of decompression. But already I know in my mind what I want to do, and it would not really change my operative plan in any way. So I personally would not get an MRI for this. I would just take it based on the CAT scan. But
yeah. So in this I started with a case that was pretty dramatic, which does need surgery. And because it is unstable, there's cord compression. It is in the cervical spine. But now I'm going to show you other cases of infection where you will be called to look at the patient, and you might be on your ER rotation. You might be on some other service. It might not be a surgical case. So, but you as whatever service you're on at that time, evaluating the patient, need to make that decision. I'm going to show you an algorithm a little bit farther along in this lecture, if we get to it, about how the University of Michigan approaches this. They have a great algorithm, which I tried to institute at USC, that is a good way of approaching based on labs, based on exam, based on imaging. And it's done very quickly because a lot of these patients need to be treated quickly, either because they have deficits or because we need to do imaging and biopsy to see what the bug is immediately before they start antibiotics. And usually you want to start antibiotic treatment on these patients as soon as possible. They're not all this dramatic. They're not all this bad. But let's go on, and we will talk about surgical approaches too. But let's go on and look at a few other cases. I'm actually not going to show this. This was a little bit of normal anatomy review, but I think we're not going to get through our 70 slides. So we'll skip through the anatomy for right now. Just take a look as we go through, though. We were talking about the normal alignment, the normal disc space height, the normal canal width. This is what normal prevertebral soft tissue should look like. You can see the difference between this and the case I just showed you. They should be flat along the anterior surface of the vertebra.
Non-existent, essentially. It should be a moot point. You shouldn't even think about it.
Yeah, and then this is the MRI. And I'm showing you a normal MRI here. We won't go through it. Actually, I will just really fast, just because I'm going to show you abnormal MRI in a second, and then Dr. Rasouli will talk about that as well. So for those of you who weren't here with us before, there are 4 sequences here on an MRI that we typically get. We get a T1 weighted sequence, which helps us look at bone marrow and helps us look at soft tissues. We get a T2, which shows us the cerebrospinal fluid, which is bright, that is around the spinal cord. It can also show us abnormalities within the spinal cord itself. There are none here. This is normal. This is a different kind of a T2 that takes out all of the fat signal in the vertebral body marrow. There's a lot of fat. That highlights any infection or edema, as in trauma, if you saw this before, or cancer in the osseous spine. And this is a post-contrast sequence over here, where if there was an abscess, in the epidural space, in the vertebral bodies, in the discs, in the cord, anywhere, that would show up with intravenous contrast. And this is what an axial T2 weighted image looks like. So just keep that in mind when you look at this. So this was that same patient's MRI. And I'll just go through it quickly. Dr. Rasouli already said he was going to do surgery no matter what. This wouldn't make a difference. And I think that's because we had the contrast-enhanced CT, which showed us the most important parts. So this is the sagittal T1. We've lost our normal vertebral body marrow signal here. We've lost our disc here. Again, I won't go into too much detail since you're not doing radiology yet, probably. Sagittal T2 shows us the cerebrospinal fluid that should be around the spinal cord. At this level, it's all gone. So we know that spinal cord is being compressed by this spine, which is subluxing or focal kyphosis, as Dr. Rasouli said. This is that T2 sequence I told you takes out all the marrow fat. So it shows the edema in those vertebral bodies. So osteomyelitis. There's actually no abnormal signal in that disc, but it's still disguised. I think it's just all squirted out the front. And then this is the sagittal post-contrast image, which shows not only the enhancement in the infected vertebral bodies, the osteomyelitis, but it shows enhancement in the epidural space in the canal. So that's epidural phlegmon or abscess and prevertebral space. So that's all that soft tissue thickening that we saw in the first few images, the X-ray and CT. And here's the axial post-contrast. Again, this looks almost like, that was a really good CT actually. Usually they're not that good. But it shows the epidural phlegmon pushing, this is the spinal cord back here, pushing it backwards, compressing it, and the prevertebral edema and phlegmon and abscess.
Yeah. Wow.
And I have a post-op picture, but you go ahead if you want to say anything about this before I show that.
So this is like a nightmare. This is a nightmare kind of case. This is really a disaster. It's really sad, unfortunately, too, because you look at if that X-ray that patient got was, if they detected the prevertebral soft tissue swelling earlier, and this patient got an MRI or some sort of advanced imaging modality earlier, I guarantee you it would have shown something abnormal, and this patient could have been just started on intravenous antibiotics, and that would have been the end of that. But now you see what happened is this is kind of the natural history of what will happen with untreated infection. So, okay, here is the problem with this patient, okay? You have a huge prevertebral infectious component that's causing significant swelling of the prevertebral soft tissues, okay? You have destruction of vertebral bodies, and you have an abscess to this, okay? This is all high up in the cervical spine, all right? And basically all of this stuff needs to come out, all right? So I'm just kind of curious if you guys can, so you know, your approach is, before I tell you what I would do for this patient, and we can talk a little bit more about that, can you guys type it in the chat box? Would you guys do an anterior approach only, posterior approach only, or an anterior and posterior? I'm just curious what you guys think.
Wow, if they know that as medical students, I'm just so impressed. I need to go back to medical school.
Yeah, let's just see. I'm just curious, and obviously, like, you know.
Actually, there are residents here too.
There is a right answer to this, but I'm just curious what you guys think. So, if you're going to go anterior, you're going to take out this infection. You're probably going to do corpectomies here, and you're going to place, you know, obviously do some sort of inner body here, and then just you're done with your surgery, right? If you're going to do posterior, right, you're going to have to probably decompress the lamina posteriorly, instrument, and then you're just going to treat this. Your goal then would be treating this with antibiotics. Hopefully, this stuff will go away, right? And then if you do anterior and posterior, you're obviously going to do both, right? Okay. I see anterior and a couple of anteriors only. Interesting.
Yeah, I wish I could vote.
I see a couple of anterior and posteriors.
Can I vote too?
Sir, can you repeat the question again? Yeah. What would be your approach? Anterior only, posterior only, or anterior and posterior?
Can we go on? Are you done? Or are you still waiting for answers?
I see a couple of good answers here. All right. So let's.
I see anterior and posterior both.
Yes, that's okay. So let's talk a little bit about this. So Wendy, are you able to draw? Are you able to draw on the images?
I don't know. Am I?
You should have a pen.
Pen. Okay.
Yes, perfect. Okay. Can you draw at the posterior aspect of C2, the posterior vertebral body, to the lamina, just like a horizontal line, a straight horizontal line from the posterior aspect of C2 to
at the base
lamina.
or mid C2?
Let's say like somewhere right above the disc. Just
like
right about
on
there.
the T2 image, is that what the image you want?
Exactly.
Like
and
that.
Perfect. Now can you do the same thing at C7?
2, 3, 4, 5, 6, 7.
Okay.
The problem is it's not quite midline there, but
It's okay. Now, can you draw a vertical line through the midpoint of your top and the midpoint of your bottom line?
this is, oops.
Okay. So do you guys know what this is called? What we're just showing here? Does anybody know what this is called? I'd be very, very impressed. Not sagittal balance, Mike, but you're thinking along the right lines. Not the plumb line, but you're thinking along the right lines. A plumb line is you would have to see a full length X-ray or full length standing X-ray, and that's just a straight horizontal line down. All right, so if you guys heard of the K line, okay, it's a type. So this is essentially showing what the K line is, and this is what we use when we're looking at anterior versus posterior approaches to OPLL, or ossified posterior longitudinal ligament, all right? The same principle can be applied to essentially any sort of ventral pathology, okay? So if the ventral pathology, which you see here, which is the kyphotic deformity, is touching that line, all right, you essentially are committed to doing an anterior approach on this patient. You must, okay? You can't just do a posterior approach only. So you can see it's touching that line, right? It's touching the K line there. So this patient needs an anterior approach. And here's the problem. This patient's bone is essentially mush, okay? When you get in there, it's gonna be like sponge. When you drill it out and you start, doing your work, you don't have good solid bone to get a good solid fusion, right? So you will ultimately, and in particular with multi-level corpectomy, which you will have to do on this patient, right? You will have to back this patient up posteriorly. So the patient needs an anterior and posterior approach. All right. So I can talk more about the nuances of that, but let's keep moving. Yeah.
There you go.
This is perfect. Exactly. This is 100%. I agree with the surgical decision making here. Yeah. This is exactly what I would have done.
Oh, do you want me to say what this is? Okay. So
yeah.
Here you have your posterior approach. Here you have a fibular graft, which Dr. Rasouli can talk about. And here you have anterior.
Okay. That I gotta agree with.
This is a surgical frame. And then, so we're looking at this lateral. So compare this to that. Okay. So I think fibular graft is important to know because that's something they haven't seen.
Yeah.
Okay, go ahead.
Okay. No, I was going to say, all right. So the surgical decision making here was excellent. All right. I don't know. Okay. So certain things I would point out are the decision to put a plate. It's a little bit proud too. Sometimes you can do this without a plate, especially in the high cervical spine. These patients often have significant, what's the word I'm looking for? Significant airway swelling, compromised dysphagia. But it was probably a good idea with a 2-level corpectomy to place a plate, okay? And then they backed it up posteriorly, C2 to 3, 4, 5, 6. I agree with that. That was a good decision. Now here's the problem that I don't agree with. They used a fibular allograft, okay? What is that? A fibular allograft is a piece of cadaveric bone, okay? Allograft in the setting of infection is that you're putting ischemic dead bone in a place that's infected. What do you think is going to happen? It becomes, in and of itself, a nidus for infection. I would not use allograft in these settings. Titanium is a little bit of a better decision, a little better choice. Now, again, I'm not going to say it's wrong. It's not wrong, but it's not the best option. Probably the best option would have been titanium, or you could even use iliac crest, which I would not use on this patient. That would be very difficult to get. But titanium is a much better choice. It's difficult for bacteria to form a biofilm on titanium. There are properties of that metal that are somewhat bactericidal. And you can, now with the more recent technological advances, you can get expandable titanium cages that you can use to place in this setting, which is what I would have used. I would not have used allograft in this setting.
Let me ask you a question. But you just said where you are, you would use the more advanced technology. This was a county hospital. So yes. What about resources? Is titanium more expensive than this fibular graft? Would this patient's care, the choice be based on that, the setting of treatment?
It is multitude times more expensive, like probably about 5 to 10 times more expensive than using allograft. The thing is that I will say that the surgical, the technical result here is outstanding, and you have to be resource conscious as well. And I totally agree. You just would have to keep an eye on this, and you would have to get serial cats. You have to watch this patient. Oftentimes, this particular type of patient, these osteomyelitis patients, have many socioeconomic issues as well too, and very complex socioeconomic issues, and their follow-up is not usually the best. Very frequently, you operate on these patients, and it's the last time you ever hear or see from them again. So you really want to be as definitive as possible, okay? Because if this patient comes back a month later, like, you got to think, what if this patient doesn't complete their antibiotics? They just, they say, oh, I feel great, I'm out of here, bye, see you later, right? What's going to happen? You could very well put yourself in a situation where this patient comes back and this allograft is completely infected and they're falling forward again and everything is completely ruined. All this hard work that you did. and the patient is in much worse scenario than where they were before. Okay, so my thought process here with this type of a patient is you have to be the most definitive and complete as possible. And if you can't do it at the hospital you're at, we are in the United States, you can consider transferring this patient. It's not an illegitimate reason to transfer this patient because you just don't have the resources to adequately treat this patient. You can send
I'm going to interrupt there. This patient they actually faced that exact situation, and they would not transfer them to a hospital which was only several blocks away. That was a private hospital. Because of payment issues, they had to be treated where they were. You're saying it's possible to transfer people in the United States. I would argue that that's not always the case.
Well, if it's a setting, and
those of you in the audience who know where I was before know where this is, by the way.
So that is not, so payment issues are not a reason that a patient can't be transferred to a setting that should be able to adequately care for this patient. It looks like the hospital that this patient was at obviously had spine surgical care, and they were probably, they should theoretically be able to handle it there. Now, if they're not able to handle it there, no, and they did. But what I'm saying is, if they are not able to handle it, then they should consider transferring this patient to another hospital. Now, I'm not going to say that. I'll preface that by saying, because you don't have titanium cage, that's not. I agree. That's not a reason not to treat that patient there. That's not a good reason to transfer the patient. However, if you did not have good equipment or let's say good anesthesia or whatever to treat the patient at the hospital you're at, you should always do the thing that's safest for the patient and transfer them to a place that can adequately take care of it.
Yeah, and I agree. I'm just saying it's not every place in the U.S. has adequate care, and that some of our audience members also might be international where there might not be hospitals with that equipment. So you do the best you can. I just wanted to throw in something real quick for everybody who is in medical school here. This case was done by residents. So all of this that you see, which probably, I don't know, what do you think, 8-hour case? John?
Yeah, I think
this was all done by, there was supervision by an attending, but this was a resident case. So you'll get to do this if you go through neurosurgery or orthopedic spine.
The residents, I'll have to say, did an outstanding job here. In terms of the technical result, is really great. They did a great job here. One of the key things I look for is look at the C2, the bottom of C2. You want that to be parallel with the floor, which it is. It's fantastic. They got an outstanding technical result here. But like I said, they just should keep an eye on this patient. You can't just say sayonara and sign off on this patient. You just need to keep an eye on them.
Yeah. Okay, let's go on. So we have like 80 slides, and I think we've gotten through 4. So we'll have to come back for part 2 someday because it's already halfway through our time. Okay. So now you're in medical school. You can read all of this stuff. I'm not going to talk about the word slides since you will study this on your own. I'll just tell you what the pictures show, and then we'll move on to more that we can discuss. This is a sagittal MRI with contrast showing discitis, osteomyelitis, or spondylodiscitis, whatever term you want to use. In this case, it was 3 levels. So this is 5, this is 4, this is 3. We've got abnormal enhancement in the end plates, in the vertebral body, a little bit, especially in this disc, although both levels were infected. And then a little bit, some of this is your epidural venous plexus. You all read about this stuff all the time, so I think you know what it is. But there's a little bit of epidural enhancement infection as well. And this is a picture from the biopsy I did on this patient. So Dr. Baj mentioned that that radiologists do procedures too. And that's true. This is one of the most common ones. We do percutaneous biopsies for discitis. I think only radiology does those. I don't know if surgery does those at all because you would do the open biopsies. But if we get to it, I don't know if we're going to get that far. I'll tell you a little bit more about the procedure for doing a percutaneous biopsy, kind of the technique to get the maximum yield, because it's often hard to get the organism. About 50% yield when we do it this way is the best we can do. And there are ways to maximize that. But
Wendy, could you? I'm sorry to interrupt you. Can you tell us what that left MRI image is? Peter was asking.
What the bug was?
Can you describe that that MRI image, that sequence?
Oh, again? Okay. So it's post-contrast. It's a post-contrast sagittal. There is fat saturation, which means, so you're going to see two kinds of post-contrast images. It depends what institution you are, the way you do them. I know Dr. Rasouli's institution does them differently without fat saturation. Good places do it this way. I'm just kidding. So you take out all the fat because fat is bright on T1 weighted images. It's hard to tell the normal marrow from the enhancement. So it's a little bit harder to see what's infected. When you take all the fat signal out, when you're in radiology, you'll learn all about the physics to do these magical things to make the images look different. You take out all the fat signal. Everything here is true enhancement, which in this case means it's infected. Well, in the bones. This is kind of complicated, too much radiology, but vessels are actually also bright. So there's a little bit more that's enhancing that's not infected, but most of this enhancement is infection. Is that a little bit more what you want to hear? Is that good? You said Peter. Peter, is that good?
Yeah, I think so.
Okay, we'll go on. Thank you. All right, so you all know this. I'm not going to stop there for diagnosis. I just wanted to talk about this algorithm quickly. I'm glad this is closer to the beginning than I thought it was. Because this tells you whether it's a surgical case or not. I think as medical students, this is one of the most valuable slides for you actually, because whatever service you're on, you might get called to evaluate these patients. And this is a good workup. So when the patient comes in the ER, so patients can come in the ER if they're, that's where they get their care. They can come in as an outpatient to a clinic, to their primary care doctor. Those are probably the two main settings, I would think, right? Those two settings, yeah. So new onset of back pain, and back pain from infection, it's insidious onset, but it often is very focal. The place that's infected is actually right where it hurts. You'll find with your exam. I'll let Dr. Rasouli talk more about that. But if you suspect discitis when they come in based on your initial history and exam, the first thing you want to do is do the complete neurologic exam. Look for the deficits that Dr. Rasouli talked about, and you want to get labs immediately. The labs you want to get, CBC, ESR, and CRP, the very most sensitive for infection. If these two things are normal, the person is almost certainly not infected, and there's another cause of their pain, whether it be degenerative, whether it be cancer, or something else. Blood cultures, which might take a little bit longer. Urinary, urine culture, I guess. I don't know. I haven't been in medical school for like 10 years, so I don't remember. So then you go down this algorithm this way. Normal neuro exam. This is what Dr. Rasouli said. If they don't have deficits, you can wait a little bit longer. If they do, then the surgeons need to get involved immediately. And I'm going to let you talk just a minute as soon as I go through this. So normal neuro exam means you have a little bit longer to figure out what it is. You want to get imaging. The first thing you probably want to get is an MRI if you can. That's not always the case. You can't get an MRI all the time. Don't get X-rays. X-rays are not going to show you anything. So at least get a CT if you can't get an MRI. If you can get it within a few hours, perfect. Like I told you, getting those antibiotics on board immediately, very important for these patients, but don't get it until you know what the bug is if you can help it. So what we do, if the imaging shows discitis osteomyelitis, like the pictures I just showed you, radiology is ready to go in there and do your biopsy so you can target your antibiotic treatment to what the bug is. Because as you know, in medical school, you all remember this much better than I do, different treatments for different types of infection. So we will get ready and do our percutaneous biopsy. I'm actually talking and not even looking at my chart, so hopefully I'm pointing to the right thing here. If imaging is normal, likely it's not infected, and we'll think about other diagnoses. But now let's go down the route that you're interested in here for neurosurgery. Abnormal neuro exam. We want to get that imaging faster. So ER docs, neurosurgery, we're all working together. We get the person into the MR or CT, whatever they need, right away. We try to expedite their imaging so that neurosurgery or the treatment team knows what they're dealing with. So that's, and then the ID consult. So let me just talk about this, and again, I'll let you go, Rasouli. So these are the three types of imaging you can get. MRI is ideal. If you can't get MRI, myelogram, which I'll show you, or which you saw last month, will at least show you the degree of cord compression, and it's a CT so you can see what the bones are doing. You see that alignment. You see if there's any destruction of the end plates. You see if there's any retropulsion in the canal, just like those first pictures I showed you. Worst case scenario, they can't get a myelogram. You can't put a needle in them because they have some kind of, they're on blood thinners or some other reason. CT with contrast, last resort, but can help you. And I'll show you a case if we can get to it. I'm going to do an image-guided biopsy. If it looks like there could be infection, if it doesn't, I'm not going to, because any procedure can hurt a patient. We're not going to just do it randomly. If they're hemodynamically stable, if not, I'm sending them to neurosurgery. And if they have a normal neuro exam. If they're not normal, then I'm sending them to neurosurgery. So now let me turn this over to Dr. Rasouli. Do you have anything to add to this? Do you like this algorithm? This is from Michigan. I think it's really good.
Yeah,
it talks about the time you give these patients.
It's very comprehensive. I'll be honest with you. When I look at something like this, my mind just gets scrambled. I'm like, what? It's like, it's too complicated. I mean, it's very, very good, but it's like, it's just too much, you know? I always like to keep things very, very simple, okay? There are generally three things. Osteomyelitis discitis, infection of the spine, is a medical disorder, okay? Generally, it's best treated with serial labs and antibiotics, okay? There are certain places where we get involved. One, if you look at the imaging and there's gross deformity or instability that's very obvious on imaging, needs surgery, regardless of if the patient's doing well, neuro intact, yada, yada, yada. Okay, 2, if there's neurologic deficit, and 3, source control. Meaning this patient's been on antibiotics forever, they still can't get negative cultures, or they don't know what the culture is, they don't know what they're treating. These are all situations where we get involved. And then
he's just talking about his little part. I'm starting from the beginning, and as a medical student, he's saying it's too complicated because neurosurgeons are simple.
Well,
so you though need to know all aspects of the care, because when this person comes in, we don't know that it's
when you're on your medicine rotation.
You're jumping in at the end. You have to let them start from the beginning.
When you're on your medicine rotation, you need to know all these things. When you're on your neurosurgery rotation, you have to know all the indications for surgery, because that's the things we care most about. All right. So this is very comprehensive, and it pretty much tells you exactly what you need to know. So the choice of surgery, meaning anterior versus posterior, fusion versus decompression only, there are many different choices that you have, is made on an individual basis. So and that usually that's something you should obviously discuss with your residents and see like what they would do. So but this is very, very good.
Nice. Okay. So these are, maybe you've kind of talked about this already. The people who are looking at the X-rays immediately, whether you're on surgery or not, these are some of the things you can look at on the imaging to know, and in the labs, to know if this is somebody that needs to see neurosurgery. So these are some of the numbers from the literature. Now, I'm not sure everybody would follow this exact thing, but this is from the neurosurgical literature or the orthopedic spine literature. I'm not sure which, I can't remember. Those are the reasons, the indications for surgery, which you've just heard. So let's go on. I want to do another case because this was a good one. So 39-year-old man, this again was in Place County Hospital, so you don't always get the best care. Although I know that Dr. Rasouli has treated people like this too. 39-year-old HIV drug abuse. So he came into the ER, severe lower back pain and caught Aquinas Syndrome. This is a sagittal CT. It has contrast, and I'll tell you why in a minute. But these little bright things down here are bullet fragments. So he got shot a long time ago, and the bullet fragments are still there. They didn't take them out. That's a whole nother discussion. But so he came in, caught Aquinas Syndrome. First thing the ER doc says, okay, I've got to get my labs and I've got to get him imaging, but he can't get an MRI because he has a pacemaker. So next choice down, which I told you from that algorithm, CT myelogram. But his INR is 4. So he cannot get a needle procedure safely. Now, I might have done it anyway if it's an emergency, but 1.5 INR is the cutoff if you want to order a lumbar puncture or a myelogram for one of your patients. Usually they can be corrected. So again, if it's an emergency, some of us will do it. But if you can correct to 1.5, that's our cutoff. That's for any kind of interventional radiology procedure, a lot of the other procedures. So this person got a CT with contrast to evaluate. And I'll just show you what this shows. There's this little squiggly line. You can still see my arrow, right? Since it's changed back from the pen. John,
yes.
Can you see my arrow? Okay. This little squiggly line of enhancement is actually a huge epidural abscess. So indeed, they did have caught Aquinas Syndrome. The ER doctor was very astute, got it right. This is an epidural abscess here on this axial image, so it's compressing the cord. So going down that algorithm, they called us first for the imaging to see what kind of imaging they could get. And so I told them in the night. So the next thing they did their comprehensive neuro exam. This person had a neuro deficit. So they went down the arm of that algorithm where they got the expedited imaging, which ended up being a CT, and then they got the neurosurgical consultation at the same time because that imaging was abnormal and showed an epidural abscess. Do you have anything to add to this one? This person actually, I'll let you say what you would do with this one. The sick person, they're very ill.
This is a very sick person. I totally agree. I mean, INR 4 pacemaker at 39 years old. I mean, this is a very, very sick person. These cases are always very challenging, in particular because I assume this patient probably came in late at night, probably on a weekend or a Friday. Is that right? Or
middle of the night, yes.
No, yeah, exactly. On a weekend or a Friday, and everyone pretty much checks out, unfortunately, at those times, and you can't get an MRI, right? It's very difficult to get a CT myelogram in some places, and you're kind of, as a surgeon, you're kind of left, and they often have kind of many different confounding elements to an exam. It's hard to get a good exam on them. They could be inebriated or intoxicated at a time, and it could be an effort-limited exam, or pain-limited exam. You just don't know, and but you have to really go with your gut in many instances and err on the side of being more aggressive. It's far better to, I would say it's far better to have, in some cases, almost a negative exploration. That is to just sit on something like this and this patient just keeps getting worse and worse and worse. And you could potentially be missing something huge. I mean, just think about if this patient's 39 years old, they're gonna live many, many more years. If they have a permanent neurologic deficit for the rest of their lives, because of inaction, that's a horrible thing. It really is a horrible thing. So I would err on the side, in particular with this type of patient, to be a little bit more aggressive. So I think all the decision making was correct here. I think is this post laminectomy here?
So he had gotten shot a long time ago, and so that was related to that. That is.
Wow,
yeah.
Another reason why.
So I don't know the answer in this case. He never got it. I don't know if he got treated. He did not get treated at our hospital. I'm not sure if he survived or what, but because of all of his comorbidities, they did not do any surgery on him. And this was the last imaging I ever saw for him, so I'm not sure.
Okay.
He was pretty ill, though. He might have died of something else, too. I don't know. He might have been septic. So
that's
hard case, though. I think, let's stop for just a second. We have like 15 minutes left. Are there any more questions we should take before we go to another case? Because remember, I can't see the chat, so you have to tell me.
Any questions, anybody?
Can we kill one?
I think let's keep going, yeah.
Okay. All right, so this, again, you all study this, so I'm not going to go through it in detail. I just want to emphasize again because I'm amazed that people don't order these. ESR, CRP, always get these when you suspect infection. I always have to, when they consult us for biopsy in these cases, they have not gotten that. I always say, please get those labs first, because if they're negative, it almost certainly is not infection. And CRP is the most sensitive. It goes up the fastest after the infection starts and down the fastest after the infection is resolving. ESR is also useful. ESR also is elevated with other, like if a person is sick, it might be that those are elevated anyway for other reasons. But if they're normal, don't ask for a biopsy because it's probably not infected. You need to start looking for the real cause of the person's pain and their symptoms. So that's all. I think white count, not always elevated, especially if they're young or older, immunocompromised. Blood cultures also, they usually have to be pretty sick before those are positive. So those are not always positive right away when you get them either. All right, let's see what's next. So X-rays, like I said, don't get them. Acute phase, you're not going to see anything. Subacute, you might start to see something, but really, if you can avoid getting X-rays, do, because the imaging lags behind the clinical picture and what's really going on. Now, if you're following them over time with treatment, after treatment, this is important for surgeons probably because this person, even though treated, continued to collapse. So you can see, we're looking at alignment. This is the lumbar spine, this time, not cervical spine. But you can see, again, alignment, well, it's straightening. We haven't got a listhesis, but it's getting straighter. This disc space is getting smaller. These vertebral bodies no longer have normal height. Getting more and more deformed, straightening out. And I've asked my virtual spine colleagues this before, and I kind of got an answer, but maybe Dr. Rasouli can answer it now. This person's been treated. When would you intervene surgically as they continue to collapse? with this
Yeah.
vertebral body.
Is that patient still on antibiotics at this point, or
At this point, this is like months down the road, like probably 8 months, so no.
Yeah, I probably at that second image, it's already time to start getting
like 4
involved in
months.
something. Yeah, because you can see where if he progressed from, I'm assuming it's a he, I don't know, but so this patient progressed from the left to the middle. You can already see that there's collapse of the superior vertebral body relative to the inferior, and you can see there's the end result of this is going to be your right-handed image. So I tend to be a little bit more aggressive on these because you know that these patients, their bone is just not going to heal, and if they do, they're going to be healing in bad alignment. And if you operate in the middle, it's a far more minimalist or less invasive procedure than the one you have to do for the image on the right. Okay. And you could potentially really make a significant impact and, less recovery time, less bleeding, yada, 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 if you intervene in the middle than if you intervene at the end. Because if you intervene on the right image, that patient needs like a full-blown like corpectomy, like a lot of stuff done, potentially. I mean, you have to get CAT scans and more imaging, but you're gonna have to do a lot more for this patient on the right. A lot more surgery could be potentially dangerous for this patient, especially if they have a lot of medical comorbidities, than if you intervene in the middle, okay? So another thing, and another great point you brought up, Wendy, is that you cannot send these patients off to the wild. You have to follow them. Even if the infection is theoretically treated, they can often have these kind of chronic smoldering infections that just don't kind of go away. And they can lead to progressive collapse and kyphosis and, chronic pain syndromes and all these problems. So it's a very challenging pathology.
Okay, I'm going to go on because there's a point I want to make that just goes on with what you just said. I don't know if we're going to get to it though, because it's about following them up. So CT, this is what you will look for. So it's a little bit better than X-rays, not as good as MRI. But what you look for, what we just talked about, the vertebral body should be normal squares with white lines around them. That's the cortex. It should be bright. Here at this level of discitis osteomyelitis, you can see we've lost, see the white lines normal around the top and the sides, the cortex. Here, it's gone. So that end plate is being destroyed by the infection. Same thing under here, all destroyed. We're already losing our alignment too. Some people are degenerative, they've already lost alignment. So just because you're losing alignment doesn't mean you're infected, but this is what we look for. One other thing that I don't know if we'll get to the case of, if you have a vacuum disc, which is a sign of degeneration and instability, it almost certainly is not infected. Just keep that in mind. I don't think we can get to that case. So here's another picture, loss of see, you should be able to draw this white line like you had a white, colored pencil or something all the way around. We've lost it right here. That's infection eating underneath this vertebral body. Two things can make it look like this: degenerative disease or infection. Now, degenerative disease, this is not a typical picture really. And it doesn't have this kind of, we call it moth-eaten in radiology. It's like it's permeative. The bugs are eating it away. When we see more degeneration, I don't know if you're going to see that at the end of this seminar or not. It doesn't quite have this appearance, but look for this on your CT if you can't get an MRI. And then, so this is what the MRI, this is optimum if you can get it. So when you have discitis osteomyelitis, this is the T2, the cerebrospinal fluid around the spinal cord is bright, so it's a T2 weighted image. Your discs are probably going to be very bright on if they're infected, like this, very watery looking, very bright. This is the post-contrast sagittal I showed you at the beginning that we went through twice. Enhancement of the body, of the end plates, enhancement of the disc. If you have disc enhancement, there's a good chance it is infected. Not always, there's a couple other things, but we won't talk about that today. And then this was the case from the very beginning that we showed you that also has not only the enhancement, this is axial post-contrast, not only the enhancement in the body and the disc, but also in the epidural space. So epidural phlegmon or abscess. This is just a really pretty picture that I put in because it's just so beautiful. This is a coronal. So you're looking at a person like if you're standing in front of them and it's sliced straight down. So kidney, spleen, liver, spine in the middle, pelvis, sacrum right here. So this enhancement right here is osteomyelitis in the vertebral body. This infection coming out the side into the psoas muscle right here This is all edema. This is a post-contrast image, so it's edema and, inflammation. This part that's not enhancing is abscess. Pretty picture. So I had to show it. This is the axial. Again, the disc actually was not that bad, but coming out the side, we see a big abscess in the psoas and the muscles and the soft tissues right here. Let's see what we got next. We won't go over that. Sometimes there are other modalities if you can't get MR, like PET. We'll skip that too, sadly. I'm going to skip a lot of these because this is all taken longer than we thought. I'll just say this. Oftentimes, this was actually an orthopedic surgeon that was getting treated. He had lower back pain, discitis, osteomyelitis. In about a third of cases or 40% of cases, you will have infection at another level. So sometimes it's good to look at the rest of the spine. He had discitis, osteomyelitis in his thoracic spine too. It didn't hurt, but we imaged the whole spine and we found another level. So just keep that in mind as well. You might want to do more than just the level you're suspecting if you can. Okay, let me do this one. We have 10 minutes left. Okay, 78-year-old man, increasing back pain. He also had swollen wrists and knees. So sagittal T1, on sagittal T1, which shows us Mayo. Again, I told you on CT, you should have that white pencil that you can draw the cortex. On MRI, you should have a black pencil you can draw the cortex. Here, it's all destroyed by the organism. So this has osteomyelitis and discitis. No end plates here. All the cortex is destroyed. Sagittal T2, bright discs, like I told you. There's also something bright coming out the front, oozing out, so that's probably infection. This is the post-contrast sagittal with fat saturation, enhancing vertebral bodies. So we've got multiple levels, enhancing disc, prevertebral enhancement, epidural enhancement, epidural abscess, prevertebral abscess, osteomyelitis, and discitis. So here's the axial image, epidural abscess, discitis, osteomyelitis, huge psoas abscesses. So these are your psoas, or these were psoas muscles before, now they're much bigger. They've got multiple marginally enhancing, centrally non-enhancing things in them that are all huge loculated abscesses. So now this person, they came in, they did have a neurologic deficit. So on that algorithm, they got expedited imaging, they got these pictures, they got neurosurgical consultation right away. Their imaging showed an abscess. So the neurosurgeons were the first ones to see these patients, this patient, even though I ended up treating, which I'll show you in the next slide. Let me just show you and then Dr. Rasouli can comment. So this is the surgical picture where they went in to clean this out. This is my picture. So I got to treat the psoas abscesses. So in radiology, whether it's interventional or neuro or MSK body, we go in there with CT guidance and I put in pigtail drains. So we sample it, we can send it off for, cultural. We already knew this one was MRSA. And then put in pigtails to drain these. And afterwards, see, I fixed him. I fixed his abscesses. Surgeon fixed his epidural abscess. And this shows the resolution of a lot of that abnormal edema within the vertebral bodies. So I'll stop there. Did you want to say anything about this one, John?
Yeah, looks great.
I don't know if there's any extra considerations. This one had multiple levels. He had MRSA multiple sites. It seemed like it was a pretty simple surgical procedure to wash it out. Is that?
I 100% agree with you. The source control was obtained by you. The kind of the spine portion of it was washed out by the surgeons. And that's kind of that's a little bit of an important nuance there, because if you don't obtain source control, right, you're not really doing anything for the patient. You're just kind of putting like a Band-Aid on this huge gaping wound. So it's important that in particular with psoas abscesses that you're treating that as well too. Very frequently that goes either it's not really taken seriously, or it's thought to be able to resolve frequently with antibiotics, when in reality it often needs to have, just like you did, Dr. Gibbs, with a pigtail catheter and kind of drain it out through an IR procedure, or sometimes even getting general surgery on board. Those can be a very tricky etiology, and what happens is you wash out the abscess, and if you don't treat the psoas component of it, it just keeps spreading to the spine, and this patient is getting better.
He actually, and he had to get his wrists and his knees drained too, but he did remarkably well. So I guess it was a bad infection, but he turned out okay. Let's see, do we have any questions, or should we keep going to see if we can get one more case? We have 5 minutes.
I don't see any questions, anybody?
And we have to take a 2-minute break between lectures. So, okay, let me see if we can get one more case here. Like I said, we have a ton of slides, so I'm kind of seeing what we've got here. This is just another case of epidural abscess. This is this. Okay, so tell us this. Okay, in the last couple minutes, if you can, is there a difference, because I think there is, if your discitis osteomyelitis and epidural abscess is in the cervical spine versus the thoracolumbar spine? Do you take these more seriously because there's more potential danger in the cervical spine?
I am far more aggressive with a spinal cord level epidural abscess than I am with one in the lumbar spine. So cervical and thoracic, if I see a big epidural abscess there, I would generally take those right away. It's a very, very different clinical picture than a patient who has an epidural abscess in the lumbar spine. Those patients can go from intact to paraplegic or quadriplegic in an hour. So you have to be very aggressive with those patients.
And that's that was why I showed that case as our very first case, the intro case, because it had all of those components. She could go bad very quickly, not only from the instability, but also from the infection and the vascular effects of being infected. So oftentimes, the deficits are much worse than you expect, even from the imaging, because of the venous thrombosis and the different vascular things going on with the infection, in addition to any kind of compression or instability. Is that, yeah?
100%.
Okay.
And actually,
All right.
one thing I want to throw in there is that vascular congestion, the venous component of that. That's actually very key because it's reversible, and you don't want to give up. Sometimes I've seen some really crazy things, like these patients with these like horrible epidural abscesses that are have these like very significant and long-lasting neurologic deficits, and it is written off. Oh no, he's been weak for days and days and days. It's not going to do him any good to take him for surgery. Those they can be reversible. Those neurologic deficits, even if they've been present for quite not like weeks, but for several days of neurologic deficit can be reversed if you take those patients. So I would say you don't want to write off those patients right away.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.